Hello and welcome dear students. Today we are going to discuss an important topic of endocrinology, that is regulation and disorders of thyroid gland. The main objectives of today's lecture are to get a brief idea about the control and regulation of thyroid hormones, to understand the disorders caused by dysregulation of thyroid hormones, and finally, we will describe the treatment and management of various disorders of thyroid. To begin with, let us first discuss the control of thyroid hormones. The synthesis, storage and release of thyroid hormone is essentially under the control of a hormone called thyrotropin or TSH or thyroid stimulating hormone that is released from the anterior pituitary via thyrotroph cells. The synthesis of thyrotropin is primarily under the control of the hypothalamic thyrotropin releasing hormone or TRH. So, the hypothalamus exerts an important and indirect regulatory influence over the thyroid hormone production and release. The release of thyrotropin initiates a number of intracellular actions which include the stimulation of the sodium iodide pump in the cell membrane, synthesis and stimulation of the intracellular proteins, that is thyroid peroxidase and thyroglobulin, also the stimulation of iodination and coupling reactions, the processes of colloid endocytosis and fusion with follicular cell lysosomes, and finally the release of T3 and T4. The circulating levels of free T3 and T4 also have a direct and indirect negative feedback effects on the adenohypophysis and hypothalamus as shown in the figure. In addition, there are other factors that influence the production of thyroid hormones. These include hormones like glucocorticoids and estrogens. High concentrations of glucocorticoids decrease the deiodination of T4 to the more potent T3 in target tissues. This is another way in which biologically active thyroid hormone levels are controlled at the target cell level. Additionally, the gonadal steroids also have an influence over the thyroid status. One such influence is that estrogens increase and androgens decrease the hepatic synthesis of plasma proteins including thyrronine binding globulin. As the concentration of thyrronine binding globulin in the blood changes, so does the amount of total T3 and T4 because of the negative feedback influence of the thyroid hormones on the anterior pituitary and hypothalamus. So, this was all about the control and regulation of thyroid hormones. Dear students, now we will discuss about the various diseases caused by the dysregulation of thyroid hormone. Thyroid failure, overactivity of the thyroid and lumpiness of the thyroid gland with normal thyroid function are the most common disorders affecting the thyroid gland. Change in the function of the thyroid presents with systemic symptoms such as tiredness or palpitations, whereas tumors or nodules simply cause a lumpy neck. Now we will focus on effects of thyroid failure. Thyroid failure affects about 2% of the population and occurs most commonly because of autoimmune destruction of the thyroid gland. Other causes include removal of the thyroid gland and pituitary failure where the secretion of TSH or thyroid stimulating hormone is affected. Thyroid failure results in a disease called primary hypothyroidism. The condition is also called myxedema. As the circulating concentration of the thyroxine falls, the basal metabolic rate decreases and patient slows down physically and mentally. So, utilization of energy therefore falls and patients lose their appetite and eat less. However, as the basal metabolic rate falls, patients may also put on weight despite losing their appetite. The consequences of thyroid failure are entirely predictable: tiredness and lethargy, lack of mental agility, and feeling cold. In primary hypothyroidism, it is possible for the thyroid gland to be enlarged, that is goiter, because of the low circulating T3 and T4 levels exert a reduced negative feedback on the hypothalamus adenohypophyseal axis, with a subsequent increase in TSH production by the anterior pituitary. This TSH, or thyroid stimulating hormone, excessively stimulates the follicular cells, causing hypertrophy. The diagnosis of primary hypothyroidism can be made by finding a low level of thyroxine, that is T4, in the circulation at the same time as a raised level of TSH. Treatment of thyroid failure simply involves replacing the missing hormone, that is thyroxine. This can be easily administered orally. The dose of thyroxine should be slowly increased until the TSH is normal in the body. Dear students, do you know what myxedema coma is? Myxedema coma is a special case and needs particular mention. If the diagnosis of hypothyroidism is not considered for several years in a patient with primary hypothyroidism, the condition slowly worsens until the patient loses consciousness. At this point, the patient is said to have myxedema coma, a condition with a high mortality if untreated. Because thyroid function tests and in particular the TSH assays are now widely available, so myxedema coma is unusual but is still occurs in elderly patients who have no relatives. Such patients who are in residential care may not be regularly reviewed, and when they become confused, they may be thought to be suffering from senile dementia. Thus, it is essential to check the thyroid stimulating hormone, or TSH, before suggesting any patient has dementia. In the unhappy situation in which such patients are not referred for endocrine investigation, several months of slowly worsening hypothyroidism occur until the patient develops coma. Because they are unconscious, this usually results in referral to casualty, where the diagnosis will be made on admission, both because of the clinical appearance of the patient and because any such confused patient would have a TSH measured. If a patient is admitted with myxedema coma, it is essential to start the patient on very small doses of T3. A usual starting dose is 5 mcg, and the reason for using such a small dose in such patients is that since the patient will have had hypothyroidism for many years, a sudden normalization of the free T3 may cause a sudden tachycardia, which could precipitate cardiac disease and ischemia, which in turn can be fatal. It is obviously important to make such change gradually. If there are no adverse events for 8 hours after the first dose of T3, the dose can safely be repeated every 8 hours until the patient awakens. It is also important to exclude other causes of coma, and since hypothyroidism is an autoimmune disease, it is possible that the patient will have more than one such autoimmune disorders. Therefore, patients are often treated for autoimmune Addison's disease, just in case the patient has both myxedema and Addison's disease. The combination of hypothyroidism with Addison's disease is known as Schmitt's syndrome. Dear students, now we will discuss another disorder of the thyroid gland, that is neonatal hypothyroidism. In the United Kingdom, 1 in 4,000 live births has congenital hypothyroidism. In 90% of cases, this occurs because of an anatomical defect such as an absent thyroid or thyroid angenesis. or ectopic thyroid. In the other 10% of the cases, the condition is due to a biochemical defect due to an enzyme deficiency in thyroxine synthesis, such as congenital deficiency of a deiodinase, an enzyme important in the recycling of iodine within the follicular cells. Thyroxine is essential for normal brain development. Cretinism is the condition caused by untreated neonatal hypothyroidism, where there is irreversible brain damage. In some parts of the world, iodine deficiency used to cause a condition called endemic cretinism, where iodine deficiency in mothers and neonates causes thyroxine deficiency either in uterus or shortly after birth, which in turn leads to irreversible brain damage. Because of the general availability of iodine replacement, it may be added to salt and to various foods such as bread. Endemic cretinism is generally a disease of the past now. However, sporadic cretinism still can occur. Even in the absence of a thyroid gland in the fetus, thyroxine is detectable in umbilical cord blood, indicating that thyroxine crosses the placenta so that at birth, neonates can have normal brain development due to the mother's thyroxine, which has passed from mother to child. Such individuals have a rapid fall in circulating thyroxine days after birth, coupled with a rapid rise in the thyroid stimulating hormone. These neonates are at risk of cretinism if thyroxine is not commenced within a few days of the birth. Because of this, there is a national screening service to prevent neonatal cretinism in many countries. All newborns have a heel prick blood sample which is screened for a number of metabolic disorders and also hypothyroidism. If a raised thyroid stimulating hormone is discovered, neonates are rapidly commenced on thyroxine. Dear students, now we will discuss the disorders caused by the overactivity of the thyroid gland. An overactive thyroid gland occurs when either part of the gland starts to oversecrete thyroxine or the whole gland does so. The disease caused by the overactivity of the thyroid gland include Graves' disease. Graves' disease was first described in 1796 by Robert Graves in Dublin, who noticed that patients would present with weight loss, tachycardia, and palpitations that would slowly get worse. In those who perished, the post-mortem revealed an enlarged vascular thyroid gland called goiter, as is shown in the figure. Graves' disease is an autoimmune disease with a number of different antibodies. One of these binds to and stimulates the TSH receptor and causes hyperthyroidism. A slightly different antibody binds to the same receptor but causes hypertrophy of the gland rather than hyperthyroidism. These commonly occur together so that patients with Graves' disease often present with both a thyroid goiter and hyperthyroidism, although that can present with one or the other. A third antibody binds to and stimulates growth factor receptors behind the eye, which causes muscle hypertrophy. These are responsible for the appearance of exophthalmos, the forward protrusion of the eyeballs, sometimes called proptosis, as depicted in the figure. A fourth antibody in Graves' disease binds to and stimulates growth factor receptors at the front of the shin, causing pretibial myxodemia, not to be confused with the condition of myxodemia, which is primary hypothyroidism. Any of these four antibodies can appear in any order, although commonly the first two appear first, causing hyperthyroidism. The third and fourth antibody usually appear about 1 year later, so that patients often wrongly blame their antithyroid therapy for their worsening eye disease. Sometimes the third antibody can appear by itself. These patients present with exophthalmos or proptosis first and see the ophthalmologists who check their thyroid function tests and find them to be normal. Note that proptosis and exophthalmos represent the same condition, the latter term usually being used when associated with an endocrinopathy. Patients with Graves' eye disease can become thyrotoxic up to 5 years later, but some never do so. A hot thyroid nodule. A hot thyroid nodule occurs when a clone of cells in the thyroid gland becomes autonomous. There may be one nodule or several. A toxic nodular goiter can occur with only very minor derangement of thyroid function or occasionally with frank hyperthyroidism. A radioactive iodine uptake or RIU test is performed for diagnosis. This involves a scan of the thyroid following oral administration of radioiodine, and it shows an increased uptake in the hot nodules with suppression of the rest of the thyroid gland. Antibodies are negative as is shown in the figure. Dear students, now we will discuss about dequervariance or viral thyroiditis. A natural history of viral dequervariance thyroiditis starts with infection and inflammation of the thyroid gland. The patients in this disease complains of painful swallowing, that is dysphagia, fever, and features of hyperthyroidism. The thyroid gland then stops synthesizing any new thyroxine and makes more viruses instead. Thus, the uptake of iodine on a scan falls to 0. Damage in this disease occurs to the thyroid follicles, which release their stored thyroxine in large amounts, making the patient truly hyperthyroid clinically and biochemically, with a raised free T3 and free T4 and a suppressed thyroid stimulating hormone concentrations. The outcome is that the patient develops a combination of clinical hyperthyroidism together with a painful neck. Because the follicular cells are not synthesizing more thyroxine, the stored thyroxine runs out a month or so following infection. When the circulating thyroxine concentration starts to fall, the half-life of thyroxine is about 10 days. So the patient will move slowly from being thyrotoxic to being hypothyroid about a month later. After a further month, with the viral infection under control, the patient returns to normal. The natural history of viral thyroiditis is as the virus attacks the thyroid gland and causes pain and inflammation, a fever, and a high erythrocyte sedimentation rate, that is ESR. Number 2, the thyroid gland starts to make new viruses and stops making new thyroxine. Iodine uptake therefore stops. Number 3, the damaged thyroid gland releases any stored thyroxine that is within the thyroid gland, causing hyperthyroidism. The stored thyroxine becomes depleted, and once the released thyroxine has been metabolized, the patient will move from being hyperthyroid to hypothyroid. This occurs after about a month, as the half-life of circulating thyroxine is about 10 days. Number 5, the patient becomes hypothyroid and stays so for about a month. Number 6, there is still no iodine uptake into the thyroid. And number 7, once the virus is cleared, thyroxine synthesis is restored. The best way to confirm the diagnosis of viral thyroiditis is to show that there is no iodine uptake when the patient is toxic. And number 9, the antibody stats may be misleading, as after thyroid gland damage, any thyroid antigens get into the circulation and immunize the patient, thus may detect anti-thyroid antibodies for about a year after an attack of viral thyroiditis. Number 10, the best treatment for viral thyroiditis is to wait for the patient to recover. Dear students, now we will discuss about the treatment of hyperthyroidism. Because thyroxine sensitizes the beta adrenoreceptor, hyperthyroidism responds quickly to beta blockade. In addition, there are 3 other important treatment options for the patients with hyperthyroidism. Number 1, antithyroid drugs such as carbimazole or propylthiouracil or PTU. These block components of the iodothyronine synthesis pathways. Number 2 is the surgical option, that is thyroidectomy. This was the original treatment used by Robert Graves. Number 3 is the radioiodine, which has been available since about 1960. Hyperthyroidism is usually straightforward to treat. However, occasionally patients become extremely thyroid toxic and this can be life-threatening. Severe hyperthyroidism is also known as thyroid storm, which is defined in any patient who is thyroid toxic together with any 2 of the following, that is hyperpyrexia, which is having above 41 degrees centigrade, accelerated tachycardia, which is about above 140 beats per minute, cardiac failure, delirium or frank psychosis, hepatocellular dysfunction. In a patient with thyroid storm, treatment starts with high dose of beta blockade, that is 60 mg propranolol every 4 hours. In an asthmatic, guanethidine or reserpine would be used if beta blockade is contraindicated. Propylthiouracil or PTU, which is 250 mg 4 hourly, can then be given, and this will take about an hour to block iodine organification. The combination of beta blockade and PTU is usually sufficient. Rarely, full control is not achieved, and the next step depends on what treatment is necessary in the longer term. Corticosteroids block T4 to T3 conversion. Iodine, either potassium iodide, that is 60 mg 3 times daily, or Lugol's iodine, a mixture of the iodine and potassium iodide in distilled water, can be used if surgery is planned. Iodine has the advantage that it reduces the thyroid vascularity, making surgery easier, provided this occurs within 10 days of the starting of the iodine. Aspirin is contraindicated as it competes with thyroxine, worsening the storm. Dear students, now we will discuss the management of a non-functioning thyroid lump. Patients who find a lump in the neck seek medical attention because they are worried that they have a thyroid cancer. This is indeed an important diagnosis to exclude. Patients who detect a thyroid lump need to have a careful clinical examination. A solitary nodule needs careful cytological examination. Patients who have a multinodular goiter do not need any further intervention. If, however, a dominant nodule is found, then that lesion also needs cytological examination. This can be performed either using ultrasound, or if the nodule is easily palpable, then by inserting a needle directly into the nodule. So guidelines suggest that such a fine needle aspiration should be undertaken twice, and if both aspirates confirm a benign cytology, then no further intervention is required. If thyroid cancer is suggested, then the patient should be reviewed by a thyroid multidisciplinary team. A total thyroidectomy should be performed, and careful histological examination of the removed thyroid should be carried out. If papillary or follicular thyroid cancer is confirmed, patients are given ablative, that is high dose radioiodine therapy, to try to remove any TSH responsive cells. Patients should then be followed up in a specialist thyroid cancer clinic, where they are usually given a generous dose of thyroxine to suppress the TSH. Annual iodine uptake scans are often used to ensure that patients remain in remission, and if any recurrence occurs, further doses of radioiodine can be administered. In general, the prognosis for papillary and follicular thyroid cancer is excellent. Medullary thyroid cancer is a more aggressive cancer and is a malignancy of the C cells. These cells do not respond to TSH or take up iodine. So, if medullary thyroid cancer is suspected, blood calcitonin levels should be checked first, and if raised, a total thyroidectomy is indicated. Patients with medullary thyroid cancer might in fact have multiple endocrine neoplasias. Dear students, it was all about today's lecture. Hope you have understood it well. Take good care of yourself. Thank you.